Welcome back again. We're going to have a panel discussion now with Drs. Butler and Dr. Pambrath. We've got some really good topics here, and I'm going to start off with, we like numbers. We clinicians like numbers. So when you're giving the iron, do you have a treatment goal? Do you have a number of iron that you would like to achieve? Javed, you first. You've gone through all these old trials and the more recent ones. Was there a limit for a number? Like I showed you, this lady went up to 80. Do we have a goal to reach?
Yeah, so this is a really complicated question, and the field is really sort of discussing. So traditionally, based on the Genzoni formula or based on weight, you replete iron, you check the iron levels, and you kind of sort of use the same threshold that you use for iron deficiency, for iron repletion as well. And then if somebody over time, 6 months, 1 year, if their iron parameters fall back into the one that got them iron repleted in the first place, then you go ahead and replete them again. There's actually a fundamental question is that, we don't necessarily do that with any other heart failure therapy, right? We don't give it to MRAs based on aldosterone or things like that. And that's the difference between FAIR-HF2 versus other trials. If you look at a HeartFit, barely anybody got any doses after 1 year. In fact, after 6 months, right? So it basically got sort of the one shot. And the question is,
was that the end of the trial? Was that the end of the trial, 1 year?
No. Patients were followed for the long run. The primary endpoint was pegged at 12 months, but the patients were randomized and followed long term. So the issue comes up is that should the IV repletion criteria be different than the criteria for recurrent injections? And what FAIR-HF2 is doing, that they will actually continue to give repeated IV iron injection unless you are concerned about iron toxicity with a ferritin level of about 800. So it's actually pretty interesting hypothesis that they're treating IV iron like any other therapy as well. So my short answer is that right now, replete the iron, get your T-sets more than 20, get your ferritin up, and then measure iron every 3 to 6 months. And if it dips down again, then you can give more injection. But this field is evolving.
And I would add to that.
Sure. Yeah, go ahead. You had given.
I would add to that is, again, obviously the ferritin with the FAIR-HF2, the ferritin cutoff 800, but there's also in the past some recommendation around hemoglobin going up if your response and you have a hemoglobin. And there's been a little discrepancy in that, like some recommendations have been 14 versus 15 cutoffs of hemoglobin of 15. And I think that's kind of where you could stop. But there's a room that, again, goes point back to what Javed just said, that there's room to, go up to there. We don't see that response clinically that fast. We don't see people jumping on to a hemoglobin of 15. So there is room in there, and whether this target of, toxicity level of 800 would make a difference. But yeah, we have to think of it in a different way. And keep checking it every 3 to 6 months. And then
3 to 6 months is what you recommend at this point.
Yeah.
Liana, if I can make a quick point. So yes, I was remiss, and Dr. Pambrath makes a really important point that you don't want somebody to be walking around with a hemoglobin of 17 and 18 and the risk of sort of stroke and all that kind of stuff. But a couple of points to that. So one is that the data are a little bit questionable, that if your hemoglobin levels are already high, by giving iron therapy, whether you will become super high, right? So you don't necessarily get an erythropoiesis response, but you still get the benefit of iron repletion. But it is a safety concern enough for another reason, which I'll talk about in a second, that I think routine measurement of CBC when you're repleting iron and just making sure that if somebody's hemoglobin is greater than 15, to not give IV iron is just good practice. The other reason to repeat CBC is because, remember, a lot of the patients may not have an absolute reduction in their erythrocyte count, but they have delusional anemia. So you think that their hemoglobin is 12.5, but they are just fluid overloaded, and then you go ahead and just diurese them, and then they get to their normal hemoglobin levels as well. So just keep that in mind. So for both of those reasons, when you're replacing IV iron, good reminder by Dr. Panchwat that we just need to make sure that hemoglobin is less than 15.
I think rounding in CCU when the patients come in shocky and they're already volume overloaded, very often they look anemic. And you're right, once you diurese them, the hemoglobin comes right back up.
Okay.
And a lot of other labs can change. So being a good clinician, it's still, it's still really important to take a look at the patient as an individual. So both of you, if I were going to put together a program that would alert or encourage, let's say, the other clinicians, including the primary cares could be doing this as well. How would you structure it? How would you do that push for people to, hey, pay attention? Just like we're doing, pay attention to the 4 pillars of care, pay attention to giving the SGLT2. How would you add this into a quality program?
So this is such an easy question because it talks about changing human behavior. So I'll let Dr. Panchwat answer that question.
Yeah, no, I mean, I think you hit it on the nail. I think it is about changing human nature, and it is about the same challenges which we have in other heart failure therapies. I think part of it is education, and I think, providing solution sets which are there. We have now, recommendations from the guidelines. We have, consensus documents. We have now trial data. The question is, how do you implement that? And how do you, build it into the system? And that's be multifold. One is education. Education is key. If you don't know what we don't know, and, we won't come down and treat those things or diagnose those things. So I think first part is, how do we actually educate? Then how do we incorporate into practice in terms of screening and diagnosis? And that's the first thing, because again, if you don't screen and diagnose, you're never going to treat them. So I think whether, depending on your EHR, you build in prompts and alerts within the system, whether you create algorithms for heart failure care pathways, whether in the inpatient setting, which most of the centers these days do have that, and you could build that into there, where there's an alert where, a patient has not had an IV iron panel checked in a certain amount of time, or annually for that matter, they should be checked. Obviously, if they have been checked and, before, and if they're on treatment, to remind them to recheck it if it's within a certain time frame of your choice. Now, from an ambulatory setting, the same thing can happen in somebody who gets a diagnosis of heart failure, and they can have a EHR flag to say, consider, along with other recommended testing, that they should have that. And if it's positive, consider treatment. So I think prompts, definitely, and we have seen prompts in other heart failure therapies showing results. So there's definitely changing human behavior without penalizing or without shaming. I think it does help. And then creating that specific pathway, and also having, I think a lot of it comes down to practicality of administration, like how to, and I think as in your hat as a vice president of quality, I think whether if you can create somewhere where it's easy for them to refer in, diagnose and refer in.
I'm working on it.
And that's what that's kind of where human inertia is. And, you tend to take the easy path, unfortunately.
And I think this is a good one for the primary cares. We're always trying to involve the primary cares more, because these patients will often see them more often than they see us, and getting them to think about it. We're doing this with the SGLT2. I'm sorry, I didn't mean to interrupt you, Gurush. No, that's right. I think the other thing is to kind of really important is that part of this has to be differentiation of, the iron indices, like what we normally are used to, this reinforcing that point, and also the formulation of what you're going to treat it. Because at the end, again, by default, like your case is going to happen, somebody's going to end up on oral iron. Even if they diagnose it right, because if they don't know, and we all justify the means by saying, okay, let me just put something on, and once they're on oral iron, they stay on oral iron until somebody catches it. Yeah, we're treating ourselves most of the times when we do things like this. The other interesting point that I was going to bring out is that when we have the patients in the hospital because they have decompensation, and even in our people waiting for hearts, you keep drawing bloods. You keep drawing bloods that you're not going to do anything with. And I think we make them anemic by drawing so many bloods. So we've converted to baby tubes for blood draws because I think the anemia is self-induced by us trying to draw blood so consistently when, what are you going to do with a CBC every single day? You're not, but at least you need one to know where you are, and you need one iron, set of studies to know where we are. So I think we have to, think about us becoming the, in fact, the little Draculas that are draining the blood off of the patient. What about allergies? Javed, in all these studies, did they report the allergic events? In other words, the patients who couldn't tolerate the iron, which I think is really small, but did they report that?
Yeah, so this really used to be a concern in the past. Remember that iron itself is pretty toxic. So in the body, it is covered, right? So in the cell, it's part of the ferritin in the blood. It's part of the transferrin. So similarly, when we give IV iron, the iron has to be sort of in the middle of some other moiety, and all these anaphylactic reactions that you were concerned about were actually in the earlier preparations and are not seen with ferric carboxymaltose. So again, one is that we should definitely not undermine the importance of safety and risk. This is really important. On the other hand, we need to keep that in perspective as well. So, like if you give ACE inhibitor, somebody can get angioedema. That's not a reason not to give ACE inhibitor, but you just watch for it and you give the education. And these are sort of rare side effects. But I don't know if the two of you actually sort of remember the numbers, but I mean, all of those things with IV iron and anaphylactic reaction, that was when large molecular weight dextran was the carrier for iron. That's not an issue right now at all with ferric carboxymaltose that we have seen.
I don't think it's even available anymore in most places.
I don't think so either, yeah. But it's in people's mindset, right? So that's what we have to fight.
Or what they heard in school.
Yeah.
Which is very interesting. So one more question. We know a lot now about heart failure hospitalization definitions. And Javed, I think you have led a lot of these thinking groups and studies that a heart failure hospitalization is very different than the ED visit, and is very different than the IV diuretic, prescribed for an unscheduled office visit, or even more different than an augmentation of oral therapy. So when you showed the MENS study, the more recent study of the 3,000 some patients, the largest studies, and the changes do not appear to be so dramatic as you would expect from FAIR-HF and from all the other studies. Could it be in the definition of heart failure hospitalizations? Did they break it down? Because the prognosis is clearly different. We know this from Paradigm.
Yeah. So this is obviously, this field is evolving, right? So heart failure hospitalization is sort of the highest risk, and then you have people with no worsening heart failure is here. So I want to really make 2 points. First of all, here is not exactly an idyllic stage. I mean, these patients, even without worsening heart failure, are at a very high risk. But then you get hospitalized, you're here. If you get outpatient IV diuretic, you're sort of here. And if you're getting sort of just the oral diuretic up titration on a persistent basis, you're here. And then we don't really have the data, but somewhere here in the spectrum will also be subcutaneous Lasix, which is now available as well. So I think this is sort of a risk spectrum of worsening heart failure. I haven't seen the detailed breakdown from the HeartFit study myself, but I think that every single therapy that we have seen thus far that reduces heart failure hospitalization have beneficial effect on these other worsening heart failure events as well. The reason why, Ilyana, the point that you're making is so incredibly important, because we don't want things to get really worse and then try to pull the patient back. You need to start up front to avoid them getting worse in the first place. So again, for IV iron replacement, the indication is not to wait for hospitalization. We need to treat that up front so you can prevent it in the first place.
Yeah, I think this is an evolving field, certainly, and as trials are getting designed, We are thinking about this when we put together endpoints, especially when we're trying to do the win ratio, of the strategy of which comes first. I have now a new favorite saying that says stability is an illusion.
Yeah.
And we can't just sit on it and think that nothing's going to happen. So with that fine note, I will bring this to a close. I want to thank both Dr. Butler and Dr. Panrath for just a phenomenal discussion and just a phenomenal teaching. And I think whoever watches this is going to get a lot of benefits that can be applied directly to their population. And so we urge the audience to think about iron deficiency. Don't put it in the back burner. It's certainly easy enough to get the blood test. The blood test is not a big deal. As I tell the patients, it may just be another tube of blood and that's it. But they can be incredibly informative, and the field continues to evolve. But I think that some things we do know right now is that iron deficiency contributes to patient symptoms, particularly of fatigue, and that don't sit on a hemoglobin just thinking that the hemoglobin is fine. And in heart failure, never look at those iron indices. So with that, I want to bid everybody a good day and thank you for tuning in.